we know what's going on. So welcome, Rishi, to our Facebook Live in our group. And I'm really happy that we've got you here because it sort of just went wrong last week. It's basically, look, I've just changed the screen, so we've got both of us on here. Zoom was deleted from my Facebook, so it just wouldn't work. But anyway, we've got you live today. So you were able to put your feet up last week, is that right?
Well, I wouldn't say I was able to put my feet up. I was able to do some other things, but I almost missed it. I was looking forward to it. These I enjoy these meetings. I think in the days of the pandemic, you can always reflect that this is the only way to meet interesting people. And I'm referring to you, Van, if you have misunderstood.
Oh no, it's always, I love having you on, Rishi, because I think we've got good banter. We get on and we say it how it is.
I think that's very important. And our patients need to know the way we think, and we need to tell them the way it is, because I don't think you can ever sugarcoat difficult decisions or difficult things. You have to tell the patients the way it is. We are all adults and we need to understand what we're saying.
Yeah, no, I completely agree with you, Rishi. We do have to be honest and just say how it is. And I think this is really important when it comes to patients that are at the moment probably thinking about surgery or recently just had surgery, because it's about managing their expectations. And if they know exactly what the surgery is going to do, I really do believe they're going to have a better outcome, because they're not expecting all these other things that they think it's going to do. They know exactly what it says on the tin. That's exactly what it's going to do. And I think that's really important.
I think that's very important. And if you don't mind, I would like to kick off with something.
Oh, go on then.
And I think all of our patients would benefit who are listening right now. And it's about bypasses. And it's a question that's asked of me many a times. And they say, oh, I don't want to have a mini bypass. I want to have a full bypass.
Right.
And I'm sure you've heard this question as well. The first thing I want to talk about is that there is nothing really mini about a mini bypass.
I'm glad you say that, because that's exactly what I say when they ask the difference between them. They go, I want the mini, and I go, there's nothing mini about the mini bypass.
Not at all. So now I've started calling it what the international nomenclature is, the one anastomosis gastric bypass, or the one joint gastric bypass. So what are the differences between these two bypasses? Well, in a standard bypass, or the Roux-en-Y, we have two joints. In the one anastomosis, we have one joint. The weight loss with the one anastomosis or mini bypass is actually higher than a standard bypass. And it comes at the expense of a bit more anemia and a bit more protein loss. And thus, in a mini or a one anastomosis gastric bypass, it is even more important to work with a dietitian, especially if you're a vegetarian. That does not mean that you can't have that procedure. You can still have the mini gastric bypass or the one anastomosis bypass. But if you're a vegetarian, you definitely need a dietitian to be helping you, because you need to have almost 80 to 100 grams of proteins a day. Once you are outside the 3-month period, or the first 6 weeks to 3 months period, you need to have a huge amount of protein.
Yeah.
But what I also want patients to understand is that in patients who are over a 60, 50 or a 60 BMI threshold, a Roux-en-Y is probably not the best option for you anyway. Patients who are over 60 BMI should only be having the one anastomosis or the sleeve. And there is a dialogue to be had there. There's a discussion to be had there. But I think the Roux or the standard bypass over 50, 60 BMI is not a good option anyway.
Why would you say that?
The risk of chronic abdominal pain. So I think the Roux bypass is a very good bypass for complication management in patients who have severe reflux. I think you can do a Roux bypass. In patients who are having a band to bypass conversion at the lower BMIs, less than 50 BMI, less than 40 BMI, you can do a Roux bypass. But 10% of the patients who have a Roux-en-Y or a standard bypass will develop chronic abdominal pain.
And how soon after surgery will they develop that?
Well, that's an interesting question. Some patients can have it early, other patients will have it late, but it depends. It is higher risk even in smoke. It's a much higher risk in smokers.
Right, yeah.
and patients who take painkillers, but overall 10% patients will develop chronic abdominal pain.
And is that related to ulcers?
That could be related to many things. It could be related to ulcers, it could be related to internal hernias. And
Mm,
what we have found is in one anastomosis bypass, the risk of chronic abdominal pain is not as acute as the standard bypass. When you cross 50 or 60 BMI, you need more weight loss than
yeah,
the 40 BMI patient. And the last thing you want is chronic abdominal pain and requiring another operation, which is why I think it should be a choice between the sleeve and the one anastomosis, because I think that is a much better option for patients over 60 BMI. And recently, one of my questions asked me that, why did you do a mini? We speak about all these procedures preoperatively, but why did you prefer a mini when you went inside over a room? And that's what I explained actually, that you did not have a hiatus hernia, you did not have any serious reflux. So I think a one anastomosis is a better operation for you because it will give you better weight loss. So that is one thing we need to educate our patients about.
right. Interesting. That's really interesting. And I mean, I find with some of my clients, and I know definitely in NHS, we used to have them, a lot of patients coming in saying, I've got this abdominal pain. Now, one of the reasons why they would have abdominal pain was they would have every scan, investigation, barium, x-ray, endoscopy, and we couldn't find a thing. They were eating too quickly. So that's another reason why a lot of patients do have discomfort or pain, and it's because it's difficult. You know, when you've had 20, 30, 40, if not 50 years of eating quickly, to all of a sudden be told by our team, by us, you've got to really slow it down, you know, and they say, yeah, I can do this. But until you have the surgery, you don't realize how slowly you have to eat, like a teaspoon of food. You've got to chew it well a good 20 times. And then you've got to, once you've swallowed, you've got to pause. It might be 30 seconds, maybe even 60 seconds, sometimes longer, you know, and it is very slow. And I think it's a bit of a shock, you know, especially when you've been eating mindlessly. So you eat quickly, or you're working, or you're doing something on the go when you're eating, driving and eating, which is very common amongst staff that are, you know, doing home visits and things like that. So I think that could be another reason why they can have abdominal discomfort after surgeries, is eating too quickly.
I completely agree with you, man. These are multifactorial points. But what the take home, so you know how I started doing surgery at Heartlands, and I was always a very strong bypass proponent. But for us, for you and me, and for our patients, it's important to learn as our experience changes. So from being a very strong Roux-en-Y bypass proponent, when we started doing other operations, I started seeing that one anastomosis actually has better results.
Yeah, it is. It's more powerful.
It is more powerful, it has better results, and the risk of chronic abdominal pain is lower. So in my patients who are having revisions over 40 or 50 BMI, and almost all my patients over 60 BMI or over 30 stone, I would usually recommend them to have a one anastomosis. It's a bit more difficult to do than a sleeve. It's and the skills required and the equipment required is a bit more challenging, but I think it's a better operation for them. So that's what I try offering them, unless I think it can't be done for whatever reason.
Right. Okay. Well, that's interesting to know. And I know we were doing them at Heartlands before I left, and I don't know. Well, actually, that brings me on to my question. How are things in the NHS with bariatric surgery and the private sector? Is it improving or not at all?
Well, let's start with the NHS. That's the easy part. There is intention to start bariatric practice, at least at Heartlands again. But the problem is lack of operating capacity. You know, we have reorganized services within Birmingham, and Heartlands has mainly become a hot site. So we don't do any non-COVID procedures there or any non-emergency procedures there.
Right.
So you suddenly have lack of so many operating theaters, and we are trying to create capacity at other places, but it is difficult because all cancer services have been displaced now. And so we have not done a single bariatric operation in the last 8 to 10 months, I think.
Right.
I don't foresee doing any for the next few months. I think our waiting list should be a couple of years now.
Well, it was a couple of years when I left in 2019. So I think we must be hitting maybe 3 years at least.
I think so. And we are doing clinic consultations still. So patients are adding on to this list.
Mhm.
Unfortunately, I mean, we feel bad for our patients. We want to help them out, but we are stuck in between a rock and a hard place. I don't think we have an option right now.
Yeah, it is such a shame because people have gone through that process of weight management, the tier 3, and they're waiting to get onto tier 4. And I mean, the waiting list was high as it was, and now to wait even longer. But it's a waiting game, right?
It is pretty bad at the moment in the NHS. I have some complex patients. You know, I like doing very complex patients. I have a few patients who are more than 40 stone, 45 stone, who've
Mm,
been waiting since the time you were there.
right, yeah.
Because I just cannot get the right kind of theater atmosphere to be able to operate on them. I need intensive care backup. I need a theater that I'm familiar with. I need a team that I'm familiar with, and I need a predictable time when I can do it.
Right.
We cannot do any complex surgery, bariatric complex surgery there at all at the moment. We can't even do the basic bariatric operations, and that's not for want of trying. We are trying, but we
Mm,
just don't have the facilities, and there's nothing we can do to expedite it at the moment. On the other hand, in the private sector, I am very, very pleased to say that we are delivering bariatric surgery safely.
right.
I think that's the most important thing. You know that I was involved in one of the largest studies, not involved in, I ran the largest COVID bariatric study in the world, which we published the first set of outcomes last year in July.
Yeah,
And
I think we spoke about it on here. Yeah,
yeah, and the next set of outcomes we are going to publish today. Actually, it's been accepted for publication.
right.
And it shows that the risk of contracting symptomatic COVID in patients who are having bariatric surgery is very low, as long as they self-isolate and follow all the precautions that we advise them to. So
Mm,
that is the good news. I know it's not good news for all patients who are waiting in the NHS, but the overall good news is that bariatric surgery can be performed safely in the private sector with COVID restrictions. And
mm.
I'm pleased to say that none of our patients have developed symptomatic COVID that have required any kind of treatment in the private sector so far.
Well, that's fantastic. Great
So
results
that's an
then.
achievement from patients and from medical staff both together, because patients are in it with us. They have self-isolated, they have done the tests. So I think we are doing quite well and quite safe. So I don't think we should be apprehensive about having bariatric surgery these days. It's safe to have bariatric surgery, and we are delivering it very safe.
Well, I'm sure that news is reassuring for our clients and patients. So that's great news. So we're going to kick off with the questions. So you're in the hot seat. Well, I think we both are. The only good thing is I've had a chance to look at the questions, Rishi. You haven't. So, but that's what I love about this. My one bit of control over Rishi. So James had a question, and this one's for you. So how does the bowel adjust to weight loss surgery? So I'm assuming for if you have a bypass, a sleeve, how does the bowel adjust to weight loss surgery?
Very interesting question. Nobody's exactly asked that question before. The bowel doesn't adjust initially.
Hmm.
And that is why you get differing things from bariatric surgery. So initially, when you had a bypass, you'll get dramatic weight loss. Some patients may even get a slight change in their bowel habits. They may get a bit of diarrhea.
Yeah.
Because the bowel was supposed to have a patient's bowel can be anywhere between 3.5 meters to 11.5 meters. So that is the variance from 3 meters to 11 meters.
A
That is,
lot of difference.
yes, that's a huge difference. And that is what we are trying to accommodate for when we're doing a bypass, especially. In a bypass, we are usually bypassing around 1.5 meters. So in the patient with the shortest bowel, you will still have 2 meters in circulation, but with the longest bowel, you will have 10 meters in
Yeah.
circulation. So patients will have different bowel symptoms.
Right.
But regardless, the body does react and they lose weight. The more important question is what happens in the long term. There's something known as gut adaptation,
Yeah.
which means the bowel adapts. The area of the bowel that, let's say it was 1 meter in the past, becomes 1.5 meters for the same length of bowel. And it starts absorbing more food. And as a result, you get weight gain. And which is why it is more important to be aware and more important to be prepared for such an eventuality. So that is what we keep telling our patients, that actually a bit of weight gain will happen after every bariatric procedure, and that is the gut adaptation. What you have to learn in the first 2 years is how to work against it, how to be prepared when that starts happening. So all the training that you've had, all the mind training and all the food training that you've had actually works for you then. That is when you need it really.
Yeah, I completely agree. And it's about, like I said earlier, it's about undoing 20, 30, 40, maybe even 50 years worth of habits and behaviors. And it's about rewiring the brain to make small changes that you can be consistent with, because a lot of our clients will be very much, they're either on a strict diet or they're not. They're either exercising or not. They don't have that balance, because that's the way their mind works. And it's about creating balance. And that's why I always say, in the first 6 months of the first year, it's so important to really work on the mindset and have good support to help change how you think about food, and really work on your barriers and your limiting belief, because if you don't, they're still going to be there in a year's time, in 2 years' time, and it needs to change. So it's not just what you eat, it's why you're eating is so important.
No, it is indeed. I think it is indeed. And that is why we have to understand that bariatric surgery is a tool. Gut will adapt. There will be adaptation. The tool will stay with you. And it is important to learn those new habits in the first 2, 3 years after surgery so that they can help you maintain this operation for life.
Yeah. And genetically, sometimes things don't work. And I think I've only ever seen, I think it was one patient, one lady in the NHS, and she had a bypass and the results were really good in the first 3 months, and then boom, it just changed. But I think there was something more hormonal going on. I can't remember her name, but she really sticks in my mind. But I mean, we've seen thousands and thousands of surgeries, and that was the one case only that I'd ever seen. And I think she went and she was added to a research trial of some form or another. But apart from that, it's only one case in all these years.
Most patients will lose weight, but what patients have to understand is that there's huge variability in human beings. The gut is changing from 3 meters to 11 meters. So people will have different results, but we should not completely rely on the operation to have results. Operation is just a tool to get us the results. I think the way we train ourselves is what is important at the end of the day to get the good results.
God, I feel you've learned something from me, Rishi. When I first met Rishi quite some time ago, he thought he was doing all the work, and I said, right, I'll speak to you in 2 years' time. He wouldn't even look at me, Rishi wouldn't.
No, I think when you start as a bariatric surgeon, you just think that bariatric surgery is the answer to all the problems.
You do, and I wish it was.
I wish it was, but it's not. It is a part of the journey. The journey will always involve a bit of dieting, a bit of carefulness, a bit of mindfulness. What the operation will do is make this mindfulness easier. That is what it is doing.
Well, it will definitely remind you if you're not being mindful, for sure, in some way or another. So, you're right. Right, I'm going to go on to Michelle's question before we start an argument between the two of us. So Michelle asked, I take quite a few prescription drugs every morning. How will this be impacted by having a bypass, both immediately after surgery and long term? I would say that obviously we recommend all medications are crushable, chewable liquid in the first 4 to 6 weeks, because we don't like medications sitting in the stomach pouch whilst it's healing. What would you add to that, Rishi?
I think the absorption of some medicines can change. So we have to be careful, like anti-epileptic medications, the absorption can change. HIV medications, the absorption can change. So some medications we have to be careful. And that is why when you're talking to your surgeon, discuss with them and detail your medications. And the surgeon should be aware that medications need to be converted to liquid or chewable format. And most of the times I'm able to guide my patients that these are the ones that you have to be really careful with. So with HIV meds, I ask them to get in touch with the HIV team. With epileptic meds, I ask them, just be careful. If you have an epileptic fit, just let us know and we will have to titrate it again, or we'll have to get you in touch with somebody who can titrate it. So the absorption can change for some drugs, but most drugs are fine actually.
Right. Okay. And the other thing just to mention to everybody is we recommend avoiding non-steroidal anti-inflammatory drugs like naproxen, aspirin, ibuprofen, because they increase the risk of ulcer formation after surgery.
That is correct. That is correct.
Yeah.
And not only ulcers, you can even, and along with that, smoking, of course.
Yeah.
Smoking and NSAIDs are two things that you should not be doing after a bypass or a sleeve or a band, because they will increase the risk of ulcers, cause problems.
Right. Okay. And we're quite hot on the smoking, aren't we, Rishi? That no
I'm
smoking.
Smoking is, besides being wrong, I just tell all my patients that you are trying to make a positive change to your life. You cannot lose weight and become healthy if you continue smoking. That is not possible, because you won't get the health benefits. You won't increase your longevity. The only way to do it is if you make a holistic change to your life.
Yeah.
So don't just have surgery, but change all the other bad things that you have to change at the same time. Make a new start. And besides that, of course, you've seen patients with me at Heartlands when they've had ulcers, and some of them who have perforated, and you have to do life-saving surgery. And sometimes you have to even reverse the bypass for such patients.
And I know that it's taken sometimes a good 9 months to 12 months to manage ulcers.
Yeah.
Yeah. And there's
So
serious things, ulcers, if you get them after surgery. So be careful. Right. Chloe's got a question here. I'm a week post-op. Tomorrow she had a sleeve. When would I expect the wind during drinking and eating to reduce?
very interesting. Did you say drinking and eating? Well, there's no eating at the moment, Chloe.
Well, no, they shouldn't be.
No eating right now, there's only drinking.
We always get a bit concerned when people say eating, and we're like, no, not yet. 2 weeks liquids only.
Well, the size of a sleeve is 34 French. Each French is 0.3 of a millimeter. 34 French is around a centimeter wide. So when you drink a bit of water or liquid, the bit of air stays trapped here. And that has to go above the water, and that water has to go down. That is why you feel a bit of gurgling kind of sensation when you're drinking fluids after sleep.
Right.
Talking about that gas, that will take some time for the swelling and things to settle down. The other gas that patients usually complain about, that usually disappears in 24 hours, 48 hours.
Right.
But if it hasn't, have some peppermint tea. My patients tell me it's very good.
Yeah, that's what I recommend. Peppermint tea, ginger tea as well, just for digestion if you're getting a lot of noises in your stomach. But I'm walking around. You have to walk around. Yes. We've just had somebody that had a sleeve, and they were just saying that they were in pain with wind, and we said, just walk, peppermint tea and walking, and it does work. So I hope that helps you, Tracy. Right, this I'm asking for about, because it's one of our clients together, and she's had revisional surgery. So she had a gastric band, she's had a gastric bypass, but she feels there's less restriction from the surgery compared to when she had the primary surgery, which was the gastric band. And do you think sometimes people that have revisional surgery, so they've had a bypass now and they've had a band before, do you think they compare how the band made them feel? Because people that have revisional surgery, and I think it's a term that was used with gastric bands and still is they talk about restriction, but the actual gastric band doesn't provide restriction. It regulates your appetite, because it shouldn't be there to stop you from eating. But I think a lot of patients expect the band to sort of stop them from eating because it's that fear of overeating. So when they have revisional surgery, now it's not all, but some people think, I'm not feeling full. My God, is there something wrong with my bypass? Is the stomach too large? What would be your comments about that?
I think you've summed it up very well. Gastric band ideally provides regulation, but most of our patients, because they haven't had somebody like you train them, treat it with restriction or understand the restriction of a band rather than regulation. I think, but it is, I just can't see how you could possibly train every patient. That's not possible. But that's how their brain works now, because they haven't understood how a band works. It's not restriction, it's regulation. The bypass doesn't even do that. It changes the hormonal levels of your body. And it's very interesting. There's some research to show that the real effects of a bypass start coming when you start having a soft diet or puree diet. Yeah. Because when you are having only fluids, that changes in hormones doesn't happen. The suppression actually starts when you move on to the second stage, which is the puree diet. And that is when separation starts happening. So I would say wait for it. It will get better. It will work. It's not a case that don't worry that it won't work. It will work.
I completely agree. And I think as soon as you start to focus on the textures, so your meals are getting firmer, denser. So you're having, like, I give a classic example of like a roast dinner with just a drop of gravy. Now that's quite a dense meal, and because there's a lot of protein there, that's when you get the fullness signals. That's when you'll find that, oh gosh, I can't eat very much. And that's when you're going to get the full effect if you have a sleeve or a bypass. So our advice is wait until you progress through your textures, and sometimes it can take, you know, a bit longer for it. We're all different and we're unique. That's why sometimes when we get these questions, I'm thinking, I don't know enough information about you to give you a perfect answer, but a general answer would be, yeah, wait until you progress to solids, and hopefully you'll start to feel the fullness signals then.
Yeah.
So I hope that answers your question. Right. Okay, so this is for both of us. Why do some people have problems with a gastric band? Why do gastric band patients need a revision? I'll answer a bit of that. Well, firstly, not all gastric band patients need a revision. We just see the tip of the iceberg, but it always seems to be that when there's something negative about a procedure, that's how we're mentally built, to pick up on that negativity. So we see the problems, but we never always take in the good results. So I think not all gastric band patients need revisions. What's your take on that, Rishi?
I completely agree with you, Van. I think I like the gastric band as an operation. The gastric band requires a team to look after you. And some of the providers in UK have a very good team that can actually support you. But I won't say it requires more engagement. It requires understanding, and it works well. Problem happens is when some patients run out of their post-op packages, and most providers have a 2-year or a 3-year package, they then start having adjustments or not be with people who can give them right advice, and that is when the problems start happening with bands. And at the same time, you start slipping away from dietary regulation with the band to dietary restriction with the band.
Yeah.
So all these things happen at the same time. The first 2 years, your guards are up and you are with a team that actually know what they're doing. But then when you start going for ad hoc band fills, that is when the problem would happen. In an ideal situation, I would provide follow-up for life with the NHS for a band, which we almost do. But it is just not practically possible. And that is why we see problems with the band, because band is a lifelong commitment from the surgeon and the patient. And both have to commit to it to have good results. Not the surgeon, I mean the whole weight management team.
Yeah, no, I agree.
From the entire team and the patient.
But I do feel the band is not always the best procedure with the heavier BMIs that have got more weight to lose. I think they need something more invasive, more hormonal, a bit more powerful to get them to where they want to be. This is my opinion. And so when I speak to my clients, and I would say, well, look, you know, you're at the higher end of the BMI scale, and I'm not sure if you're going to get the results that you want, you know, with the band, and maybe the bypass of the sleeve or the one anastomosis bypass might be the better option. So, you know, it's really having a thorough assessment with someone like Rishi or myself to find out what is the best procedure. But also, I agree, I think with gastric bands, you need to be assessed correctly before the band is adjusted, because, you know, we always think that, you know, you need to keep having more and more fluid in because you're chasing that restriction, that tightness, because you've told that's how the band works, but it's not. It's to help you feel satisfied on small portions. So it's not there to stop you from eating. And when the band's too tight, people put weight on. And so they think then they need more fluid in the band, but then it just limits you to having sliders. So you're going to opt for things like milkshakes, chocolate, ice cream, anything that's going to slide past the band, because that's all you can get in. And then that causes something called maladaptive eating. So you don't want to eat proper food, you want to survive on those sorts of foods. And because you used to enjoy them in the past, you'll just carry on. And then until you get to a point that you're not happy with your weight loss, and then you get assessed properly. So if you're having your gastric band adjustment, you must be assessed properly about your diet, ask about any problems that you're having, the amount of fluid that you've got in there, and then it should be adjusted or fluid taken out, depending on what the assessment tells us.
But you touched on a very important topic about weight and bands. You will be very, I'm not sure whether you know, as of the 1st of May, at Healthy Weight, we keep on looking at results. And you know how my views as the medical director of Healthy Weight always was, that we should try doing the best for our patients.
Yeah.
By looking at data more and more, and all the data I've appraised, we've agreed that we won't offer any bands to patients over a BMI of 50 now.
Right.
Because we have seen that patients over a BMI of 50, one, don't get good weight loss with the band. But more importantly, their ports are difficult to locate. They have to have an X-ray every time. It's more disruptive for the patient. They have to get more radiation. And at the end of the day, they not all get good weight loss. So the proportion of patients who get good weight loss after 50 BMI or 60 BMI with the band drops to 5-10%. And I don't think we will be doing a good service to our patients if only 5% are getting a good outcome. So we are
I agree.
At all to any patients over 50 BMI now.
No. Oh, that's great. Great news.
Step in the right direction. I'm not saying I don't like bands. I'm saying that let's concentrate the right surgery on the right group of patients.
Absolutely, I agree.
Let's not waste our time trying to adjust bands at BMI 60 when we know that 90% of the time it doesn't work. Let's get that expertise to a band where I think we can get good results.
Yeah, absolutely. Right, we've got a question here from Kirsty. I think you're speaking to Kirsty tomorrow. So her first question is there a best option when it comes to contraception following weight loss surgery? And don't say abstain.
I was about to say that.
We've got to be realistic.
Okay, definitely not the next day after surgery.
Yeah.
So that abstain for. I think the first 6 weeks, I would suggest that use mechanical protection. The first 6 weeks after surgery. But after 6 weeks, I think you can go with either the mini pill or the combined pill. But remember, the absorption of the pills can be different slightly.
What about the implant?
Oh, implant is easy. Implant is fine. Implant is progesterone only. You can go with the implant. The mini pill is fine because it stops the periods completely.
Yeah.
You know that you are very unlikely to get pregnant. But the combined pill, the absorption can change. So the combined pill is the one that where you take 24 days and you stop for 4 days.
Yeah.
Absorption can change. And if the absorption has changed, then you could get into trouble. So I would suggest the progesterone only pill or the mini pill or the implants. And after 2 years, when you think your absorption has settled down and everything, you can then have the combined pill if you want.
Yeah. Okay. Right. Great. So then her second question is, and I think it might be me answering this. I'm interested to know, but you can help as well, Rishi, because, you know, I've trained you well. I'm interested to know long term what you recommend in terms of diet and exercise following the sleeve. What food groups should I be focusing on, be mindful of, and how much exercise should I be aiming for? So again, Kirsty, I know I've spoken to you. We don't know very much about you, but everybody is very different according to what they do need immediately after surgery and what they'll need at 3 months, 6 months, or in a year's time. So it's not about removing food groups. It's about making sure that you've got a good amount of protein in your diet, plenty of salad and vegetables, and you still need carbs. I think a lot of people want to do keto after they've had surgery, but it's just another fad diet, and keto isn't sustainable. Do you agree, Rishi?
Yes, I think I won't say I'm an expert in diets. I've never dieted.
We've tried to be mindful about what you eat at times.
Well, I remember the days when you used to make some soya for me and bring it to work. And my God, it was difficult. I can tell you that.
So, I used to take salads in for Rishi to try and convert him to eat healthier food.
The man is a great dietitian, but she's a bad cook. So go with a dietary advice, but not with a cooking advice.
I have to, you know, I'm one of these people, I can cook, but don't cook. But my daughter, I've trained her well. She's really good. So when she's here, she's in the kitchen now, actually, putting together something. So, you know, you've just got to train the right people. But I would always say, don't eliminate food groups completely. And I know all of you out there are like, oh, yeah, no carbs. Yeah, cut them out completely. Don't, because your body will crave them and then you end up binging on them. So don't cut out food groups. Yeah, you've got to be mindful, and exercise, again, very individual advice. We don't know what sort of level of exercise you were doing pre-surgery, so it all depends on that, what your fitness levels are like. But the one thing that I do say to all my patients is, don't do any heavy exercise or intense exercise, definitely the first 6 weeks, because your body's healing, right, Rishi?
Yeah.
And then after that, I say, and I think Rishi always sort of looks at me when I say this, I always say, even after surgery, don't do anything strenuous until you hit your first major weight stall. So walking, just movement is great for the first 3 months. You don't need to do anything intense.
I think I agree with you almost on all accounts. I think moderation is with food, there's nothing better than moderation. Not do extremes. Extremes are impossible to maintain. Take out carbs completely, you just can't do that. It just won't work in the longer term. Only have a protein diet, it won't work. Only have a keto diet, it won't work. I think moderation, the whole point of having surgery is that you can almost lead a normal life with some restrictions. If you're going to live a life with only full of restrictions, well, I just don't think it's worth having surgery then. The aim is we are trying to get you to an almost normal life. So moderation in everything is important. I think
this is where the mindset coaching, changing your thoughts and feelings around food is really important, because your program, if you're at a point of having weight loss surgery, you've done every diet under the sun. I know you've done everything. So you've got this dieting mindset of, I've got to restrict, I can't have these certain foods. And Rishi's right, there's no point having surgery if you're going to restrict everything in the diet. The only time you need to avoid foods is if they're going to make you dumb. So if you feel really unwell after eating sugar or fatty foods, or if you're eating and drinking together, but otherwise, ideally, you shouldn't be restricting food groups completely. But yes, we do need to be mindful of certain foods, but not cutting them out completely, because your body will just crave them and then you end up binging on them. And then your surgery isn't going to work. And what a waste of money, right?
I'm completely with you on that, yes.
Okay, so Heather's got a question here. I'm just over 4 weeks post-op. She had a sleeve. I'm finding the hardest part of it all is eating slowly. We've just spoken about this. Well, waiting between each mouthful. Does this take some getting used to, or will it be easier when I'm on normal solids? I'm currently on soft food. So let's see what you've learned, Rishi, from what I said earlier.
20 times chew and 20 seconds in between. There you go.
You see, Rishi, this is the thing. You can't listen to the surgeons for the post-op advice. They're focused on getting that surgery and doing it safely for you. This is where the dietitians and the nurses come in to help you work with your surgery. So it is a small bite of food. It's around 20p. You've got to chew it well, might be 10 to 20 times, and then you've got to pause minimum of 20 seconds, maybe up to 60 seconds, depending on the texture of food. But the meal
in 5 minutes, man.
I know your dinner's done in 5 minutes. Gosh, I need to come back to the NHS to sort you out. But your meal should last 20 minutes. And the reason being is that's how long it takes for the brain and the stomach to engage in that satisfied feeling. So if you're eating quicker than that, you are still going to want to eat. So that's why it's really important to slow down your eating, whether you've had surgery or not. It takes about 20 minutes for the brain to regulate and recognize that you've eaten a meal and to feel satisfied for it. So does it get any easier? No, it doesn't. But what you'll find is practice. The more you practice, the more normal it will start to become, because it will become a habit. And the other thing that you'll notice is that when you eat soft food, it's easier to get that food down. But when you eat a denser meal that's firmer in texture, it's going to take a lot more effort. Now, I'm just going to tell you about something that it's a handy little hint to know. I've got this saying, sloppy diet will give you sloppy results. And the reason behind that is because when you eat sloppy food, one, it's easier to eat. You can eat quickly, so you're going to eat well within the 20 minutes, but it slides into the stomach and it starts to slide out. So the fullness sensation disappears. Whereas when you eat a denser meal, so I gave you the example of the roast dinner with just a drop of gravy, because that meal is firmer, one, you've got to eat slowly. So the likelihood is your meal is going to take about 15 to 20 minutes. Because it's dense, it's going to sit in your stomach for a lot longer than a softer meal. So that's the importance of eating denser meals compared to sloppy foods. Sloppy foods, you can eat more of them and they're quicker to eat. So just to be mindful.
No, I agree with that, actually. Yes. Consistency and the type of food we eat is quite important.
There's so much information to take on after you've had surgery, and it can be overwhelming. So I can completely understand why you might think, oh gosh, you'll listen to a certain bit of information and take that on. Now, I had a patient the other day, and she heard in a group chat, protein. You'll be really impressed with this, Rishi. She was really struggling with protein. She was probably getting about 40 grams in a day, which I thought was quite good in the first few weeks of surgery. And when I spoke to her again, she had about 160 grams of protein in her diet. I had to say, right, we've got to halve that. It's too much. So you grasp onto things, and she heard protein. So everything became about protein shakes, protein water, adding whey protein to protein water and her shakes in. The body can only consume and use up about 25 to 30 grams of protein at a time. So if you're having more than that at mealtime, it's not being used as protein, it's going to be used as energy. So just be careful about that.
No, I think you're right. It's very important for patients to understand that all of us have different roles in your weight loss journey. When I see a patient preoperatively, I talk to them mainly about the operation, the choice of the operation, the risks of the operation. The reason why I don't talk about that is two things. One, I don't know so much. And second, if I start giving you all the information at the same time, you won't retain the information that I want you to retain, which is about the surgery first. And which is why we have specialists throughout your weight loss journey, as and when you need them. And they will do the best job for you at different points in time.
Yeah, no, I completely agree. And it's a scary decision, having surgery. Secondly, everybody likes to keep it a secret because they get judged. There's a real stigma around weight loss surgery. And thirdly, there is a lot of information to take in, and you've got to change your whole lifestyle, your eating, your life, everything changes. It's not just your weight. You will change as a person. You'll probably become more confident. There'll be other things that you start to learn about yourself, and it opens up a whole other can of worms, but it's a good can of worms, I've got to say. So, go for it. If you want the surgery, go for it, and speak to Mr. Singhal or myself, and we can help you get to the right choice of whatever you need. Right. Let's see. Donna had a question. And it might be for both of us, how can I speed up my loss of weight from 1 to 2 pounds a week? And what are the best foods for protein, as my sleeve doesn't like chicken or eggs? So I might help you, Rishi, with that one. At the moment, it's baked beans and with everything she's having. So how can I speed up my weight loss from 1 to 2 pounds a week? Do you want me to start?
What is the need to? I think the first answer is, what is the need to speed up the weight loss?
Absolutely. That would have been my question as well. Why? That's a good weight loss.
I think so.
And you know why this is? This is like, we get it with every patient, because when you go on a fad diet, like your Light to Life or your Cambridge, you guys are losing 4 or 5 pounds a week. But what you've got to remember is, what you actually losing, the likelihood is it's fluid. You're not actually losing fat. And so when you've been on these fad diets for so long, and also in the initial stages of weight loss surgery, you're going to be losing a lot of weight quickly. And again, that's because a lot of it is fluid loss. But you get used, and you get obsessed about, oh my God, I can lose 4 pounds a week, and you think that's the normal. And then things start to settle down. And I have to say, losing half a pound or a pound a week is fantastic weight loss. So if you're losing 1 to 2 pounds a week, I don't think we need to do anything there. Just go with it.
I think you just have to be patient. This is not a 100-meter race. This is a marathon. Yeah. This is not even a marathon. This is a lifelong race. So there's no need to run right now. Just keep on walking and enjoy the journey.
Yeah, absolutely. I completely agree. And with regards to protein, chicken is a lot more difficult because it's a denser protein. But let me tell you, that means it's good. It just means you need to slow down with the eating. If you are in the earlier 12 weeks post-op, so it is still probably a little bit soon, but I would just add sauce to that just to help it go down a little bit right now. But, there's eggs, pulses and lentils, mince is good, corn, soya, tofu, dairy products, yogurt, milk, cheese, egg, nuts. There's so many different types of protein foods out there. What I would do is I would probably go back to your aftercare team, Donna, and ask for a little bit of support with regards to your diet. But to be honest, 1 to 2 pounds a week at 12 weeks is fantastic weight loss. So accept it, it's good. And I think Rishi, I've got one more question here. It's something that I saw in the group, and Rishi, you might want to say something about this, but I'm seeing lots of posts about what to do before and after a gastric band adjustment. So if people don't know what to do, first of all, you need to speak to your aftercare provider. And I know what you're going to say, we can't get through to them, but you've got to go through the information that you get in an app or an email, because there will be advice about what you need to do. So generally the advice is don't eat anything 3 hours before you have a gastric band adjustment. Fluids are fine, but 3 hours before. So whether it's done in X-ray, or if you're having it done in X-ray, I just wouldn't eat at all for that day. So it's in the afternoon, just stick to fluids. After you've had your gastric band adjustment, it's 3 days of liquid. Sometimes it's a little bit longer. It can be up to 5 days, depending on your aftercare provider and how much fluid has gone in. And then you will need at least 3 to 5 days of soft food. And that's because your band is going to be quite tight when it's initially filled, and then it will start to relax. And then you slowly progress to solids. Have you got anything to add to that, Rishi?
I think I'm even more strict with that. I agree with
Are
that.
you?
I tell my patients when they ask me the rule of 2-2-2, 2 weeks of liquids, 2 weeks of puree, 2 weeks of semi-solid, even after adjustments. Maybe I just know one style.
Yeah, no. Well, we never said that in Heartland's hospitals in the NHS.
So mine is 2-2-2. When you have a band adjustment, if they ask me, unfortunately, that's what I will say.
Right, so the advice is don't ask Mr. Singhal about what to do after a gastric band, unless if you do want to do 2 weeks of liquid.
Just want to start for 6 weeks completely.
Yeah, but again, it's the same with the gastric band. Everyone always, after they've had an adjustment, some people say, oh gosh, it's quite tight, and you just have to wait for it to relax and give it a couple of weeks. Some people who are probably on your liquids for 2 weeks because they've come and seen you, they'll be like, but I just can't feel any tightness from the band. And that's because you're on liquids. You're going to feel the band working when you move on to solids. So be patient, but definitely you should not be eating food straight after you've had a gastric band adjustment.
That's correct.
Right. Okay, right. We've been on for 50 minutes and I cannot see, oh, hang on. I can see if there's anything else here. Let me just see. Oh, it says here, Chloe said, when you're mentioning training yourself after surgery, what would you recommend? Any specific support services or knowledge to draw on, please? Yeah, I'm going to say myself. Come and speak to me, Chloe, if you've not got any support, because it's not just about nutrition and activity, it's the whole lifestyle change and mindset shift. So, Chloe, if you're interested, what I'll do at the end of the chat, I'll put my link to my discovery call, and you can book in and we can have a chat if that's okay. Let's see. I think that's it. I think that's all the questions. So Rishi, we'll get you. When are you back from India?
Well, I'm back in end of June, around that time, but I'm quite happy to join you from India. Well, you know, I will be in lockdown this time, so I won't be going out and clubbing and partying. So I'm quite happy to talk to you. I think I'll take this.
And when you come back, don't bring anything back with you.
Well, I don't think that would be a chance. I'm going to stay at home and not get out at all.
Oh, bless you. Well, look, if there's anything that we can do for you going to India, if there's any support and so forth, let us know. And I'll speak to you again soon anyway, but we'll arrange a date for when either whilst you're out there or when you're back.
Yes. Well, it's been a pleasure as usual. It's fun. Thank you.
No, it's great to have you, Rishi, and I'll speak to you soon.
Thank you.
See you. Bye. Bye. Bye, everybody.